Hello, welcome to this conversation on themes from some recent social research into family, domestic and sexual violence in Tasmania. My name's Martin from the Australian Centre for Social Innovation. I'm here with my colleague Carla and with Monique, Angela, Holly and Tim from Primary Health Tasmania. We thought we'd get together and have a chat about themes emerging from the work and possible ways forward being supported by PHN Tasmania.
This is Carla here from Taxi. We've been on a journey with this wonderful thing called the RRR model, Recognise, Respond and Refer. And we've been on a journey with it since about 2018 in mighty yet humble beginnings in Brisbane South, with and alongside the Brisbane South PHN, where a really important state-based inquiry into the prevalence of family and domestic violence had essentially given the state a bunch of really important recommendations for everybody to actually organise better, to leverage strengths and actually to have a really coordinated response where everybody as part of the system had a role to play. And one of the recommendations within there was about what is the capacity or the capability building uplift for primary care. And Brisbane South were at first sort of tasked with working out what that would look like. And we worked alongside them to essentially design what is now known as the RRR model. But what was super, super key about that model is that it really was seeking to meet different primary care professionals, mainly doctors in general practices, really meeting them where they were at with their understanding of this social health phenomena, this public health emergency. And so a lot of it was really around how could you design a model to really meet GPs and practice professionals really where they're at about finding their confidence and their role and really supporting them to actually step into their role. Because why they were named as a recommendation is because they're extremely uniquely positioned in our society to have one-on-one conversations, quite unlike other and many settings in our world. And so herein lies the opportunity that, well, evidence was telling us that people want to disclose family and domestic and sexual violence to GPs. People were attempting to do so, but we knew that we just had to actually make this a very intentional part of confident practice moving forward. So the model sort of became its thing. And if we sort of fast track from 2018 to now in 2024, there are now 12 PHNs across Australia that are at different stages of adopting and adapting this model to place and to people and to priorities and to needs. And that's what's particularly unique about this scale opportunity for Tasmania, is because, yes, there was really great work done to design that model, but Tasmania have really taken a fantastic, great step forward in looking at, well, how do we deconstruct and reconstruct that model to really authentically meet the needs of victim survivors in Tasmania and give primary care every opportunity to step into its role with great support and great confidence. So it's a really wonderful opportunity and a really important opportunity. A couple of other things I might just name that we may sort of know of from a broader sort of national response is there's been a really interesting rapid review of prevention responses done recently in Australia, and there's a great report called Unlocking Prevention Potential. And it was actually really sort of humbling to see that one of the recommendations in there was all about, again, primary care's like very unique position to do good work and to actually do good work with meaning that can prevent violence from occurring in the first place or from occurring again. So yeah, I think I just want to sort of applaud all these PHNs that are seeking to do this in quite a complex space where I think what this is also asking is that the role of the PHN is kind of changing and evolving as well. So I just wanted to name the great work that's been done already for a number of years, and look forward to seeing Tasmania's journey evolve. So to bring this model to life in Tasmania, Primary Health Tasmania kindly invited us to walk alongside you to do just that. And there was quite a roadshow that was led by Martin and another colleague of ours, Pallavi, where Monique, as you were saying, like we really did try to meet people where they were at and really deeply hear from people, from GPs, from practice staff, from folks across the broader FDSV sector, to really understand how we could do this shaping of the model to best serve community. So I might just ask my dear friend Martin to tell us a little bit about when you landed in that beautiful place of Tasmania and what you did.
Yeah, thanks, Carla. Yeah, it is. It's always important to start with building on everything that's been done in this space. I think regularly, we're asked to do work that, gets to the heart of an issue, and often the heart of an issue has been said, shouted, hollered at systems and the government like for a long time. So just acknowledging as well that we really didn't want to go out and ask the same questions this time, and because it was a really great opportunity to understand what this RR model, triple R model, is. What would that be like in the Tasmanian context? What is that like for Tasmanian GPs? What's it like for people that are working out on the East Coast? What is it like for people that are working in Northwest? And I think so. We designed a really broad engagement and lots of types of invitation to people to be involved. We did a whole bunch of calls and a whole bunch of emails, and we used the existing kind of lists that the PHN had, but also big lists of medical centres and private practices and general practice to invite people to take part. And I think quite quickly we realised that the initial hypothesis of we'll have a Hobart workshop and we'll have a Launceston workshop and we'll get loads of folks together and we'll be able to talk about it. That just wasn't really going to be a thing. And I think we realised quite quickly that we needed to borrow Holly's car and and rent our own and go on a bit of a road trip. And so, and what was lovely about that is like meeting people where they were at, was that we just got lots of different types of opportunities. So, for example, we were invited to be part of a whole company all in Devonport, which was just a real blessing because we got to speak to not only specialist practitioners, but also all of the people that work behind the scenes that can talk about all of the operational challenges that might sit behind this thing. So we got to speak to them, and they just worked gloriously on some of the basic questions that we had, but really gave us an incredibly rounded picture. And we were able to speak to networks of NGOs working together in this sector and how they think they could work better with GPs and specialist sectors as well. We did a big trip out to the East Coast where we got invited to spend some time with a practice, and they just got their whole practice in the room at various points, mostly because I bought cookies. But they very happy to bring everyone along and have a yarn about what's happening and how this would be tricky. So we got to meet the AMBOs there who go out to people's houses, and what does safety and risk look like for them when they're working in this sector, and how do they work with GPs, and how do they bring that information back into a broader understanding. And I think just getting that in-person practice-based conversation really showed us the wealth of strengths and knowledge that's already in practice, especially in rural and regional locations. Like they already know that they're playing an incredible role in this family, domestic and sexual violence space. They know that they're playing a crucial role in community, but and they're a real passion for doing more and for learning what that takes. And I think there was a real learning there about what it takes to not just do the training, but what it takes to put that into practice and how they might actually approach that, not from a here are the individuals that have done the training, but like as a practice, we have decided that this is how we can best support our community. Yeah, and through that we got lovely connections and referrals to like, oh, you should speak to this council, they're doing some amazing work. So we heard about all these extraordinary community-based activities that are happening, and all the what we came to call sort of discrete places of disclosure and support that women can seek, and yeah, so there's less formal supports. So we got to speak to people who are running those too, and which gave us a really unique insight into really the nature of the ecosystem that is built up in Tasmania, like through necessity, and just all those pathways that are there for women, but maybe they're not connected into more formal supports, and what could that look like, and just enabled us to really learn from people in very local situations what that was. Yeah, having said that, we did do a Hobart workshop, we did do a Launceston workshop, which were both extraordinary experiences as well, bringing different people together, introducing people to different parts of the system that they may not have known about, and highlighting for us, some of the gaps in knowledge that some of the real quick wins we could have in this space as well. But yeah, through all of those conversations, really rich conversations, we also invited people online to meet, when at a time that they could meet. We spoke to some people with lived experience of family and domestic violence as well, opening up a very particular individual space for them to make sure that they were safe to talk about their experiences and what could be better from their point of view. And we ran surveys and gave people opportunities to feedback in lots and lots of different ways. And so this report that we've put together at the end is really a culmination of lots of different engagements, lots of different types of engagements, and really trying a few different ways of engaging people in community, so that we can step a little bit outside of, I guess, a broadly understood challenge, and what does that really mean in Tasmania. Yeah. But it was what was really great about it was working so closely with the team in the PHN, who came along to some workshops. Holly, I don't know whether you want to talk a little bit about your experience of just being out on the road and speaking to people firsthand, or just listening to people. It's I know it was a really profound experience for me, but it'd be interesting from a PHN perspective, yeah, what that was like for you.
Yeah, thanks, Martin. The thing that really stood out to me about our road trip, as we call it, is even though I'm a local-based Tasmanian, I've lived in Launceston, I've lived in Hobart, I've lived down in Margate, so even a bit further out of town. When you go to those really specific rural areas that we visited, every place is uniquely different. And so you get to see what's happening where they are. And so you understand, I guess, their challenges a bit better. And we also got the chance to sit in the coffee shop and have coffee, and then you'd go to a practice and they say, oh, the ladies in the coffee shop are actually helping out in this area. And you think that's just so amazing to know what the local people do within their community. So I think that was a unique thing about us actually getting out and travelling around.
Yeah, it was certainly a fantastic experience. And also I find that, just when we were working alongside each other, instead of it being a sort of a contracted, okay, we'll go out and get the data and then put it in a report and that's the way we communicate back to you, we're able to have this sort of real-time conversations about what did we just hear, like, oh, that's interesting. And then you could kind of take that question into the next into the next interview that you did, or just sort of walking through Hobart on that incredibly windy afternoon. I remember and it was just just being able to have a chat with each other about like, oh wow, that was really interesting, and just unpack things over time was a really valuable part of the process. So I really value that, working alongside the PHN on this, because I feel like there's so much more that can be learned through this type of conversation and working at that pace. And yeah, Angela, it was great like having you in the workshop as well. Just hearing real time, like often there's these sort of gaps in knowledge between different parts of the system. And yeah, just I'd be interested to hear from your point of view what your experience of that workshop and what that was just like, sort of joining up bits of information.
Thanks. I think the take-home message for me was that everyone sitting around the table was so closely located to each other, yet didn't know each other existed. And bonds could be formed just in that workshop. And I could see referrals were going to be happening the next day. People were exchanging numbers and were going to communicate from there. So just the immediate impact. And answering some of the questions, some of the people didn't know what certain specialist services actually did or what the referrals were, especially, say, when child protection services maybe should be involved and what could be done even before then. They were the messages for me.
And I think we found that across the board, even with travelling outside of the workshops as well. Sometimes it was, oh, we don't really have any services in this area, but because us as PHT had been discussing things with our specialist sectors, we did know that there was someone available only a short distance away. It's just that people don't know where to refer to, which was a huge barrier that was picked up across the board in all areas.
So they might be looking in their LGA, yet just over the border, if we say it that way, it would have been a closer referral.
Yeah.
There was some of the distances were surprising.
Yeah. And even as you said, Angela, around people not knowing when to refer, I think even the understanding of what referrals certain places would take was a huge gap as well, because they could refer on thinking, I have a suspicion of something happening, and these people look into it. But the understanding of the person sending the referral is, I have to know for sure that something's going on here, which is not always the case. So I think even just learning that small bit, that if they have an inkling, they can refer to these people to look into it, is another gap that we noticed.
Yeah, absolutely. And all these things, like, seems so simple. It's just like, oh gosh, hang on a second. So we just had all these quick wins that we're able to kind of draw out in the report. So we're not talking about massive system change. We're literally talking about awareness of the services that are available. What happens when I call that number? Like what will happen if I make that referral? What will happen to that family, or what will happen to me? Will I have to share all my notes, or what impact is that going to have on me as a or what impact will it have on me and my relationship with my patient or their partner or the rest of the community? Like, what is that? So we're really interesting sort of barriers, not only in knowledge, but also in, I guess, that, just awareness of what's going to happen next. It was just, and that sort of stuff really, that was actually, I really appreciated the generosity of people in that session, like being really open about that. And it was really great to that we could set up that space so that they felt safe enough to do that. That was they're very, very generous with their sharing of that. But yeah, there were so many sort of quick wins. Even just the awareness of practitioners about how prevalent this issue might be, and the fact that some were really saying, oh well, we saw 4 cases last year. And just thinking about, well, the amount of people that might be experiencing, violence in their lives or abuse that could be addressed, but actually isn't disclosed in that situation. and maybe then, you know, that would sort of lead on to like, you know, many of the recommendations about just about awareness of the many forms and presentations there might be of violence, and the way that people test a system, or test a practitioner to see whether it is safe for me to disclose here. Like, is it, what's going to happen if I talk to you about this? You know, what's going to happen next, and the lack of a sort of awareness of that. But yeah, and then there was a really interesting one just about screening as a routine practice. You know, if we talk about, you know, before receiving medications, okay, are you taking any other medications? Are you pregnant? You know, how are things at home? You know, adding that question to a general screening thing might not open up a conversation right there, but over time, you know, that's a place where someone's going to ask. Someone cares about that. And so these are like not rocket science sort of things, and they're also not hugely time consuming either, in terms of like just that initial inquiry and curiosity about people's well-being, because I think obviously let's just name that as a big concern of general practitioners, that they're just massively constrained for time. I don't know if anyone wants to pick that up, or Carla, you want to sort of talk a little bit about that, but that's something that's been over and over again. It's like, well, how I only have a 15-minute appointment. What if I open something up and it takes longer, or it should take longer? What can I do about that?
Thanks, Martin. Yeah, I think that's sort of wherein lies one of the opportunities, I think, just from listening to what you were all reflecting upon there, as we sort of went along and had lots of yarns and conversations and looked at different evidence sources. There was a number of sort of, I guess, themes that popped out in the work. And one of those is about like supporting collaboration. And I remember being in one of the GP consults online that we did, one of the yarns with a small group of GPs. And I remember right at the end of that session, one of the GPs said, you know, I came here to contribute my perspective, but I've actually gone away having learnt so much about what I can actually now do in my practice. And so to answer your question, Martin, or just to yarn about it more, I think it was very interesting because, yes, we know that the time constraints within general practice are already incredibly confined. And we're also, you know, on the other side of the coin, we heard loud and clear from the family, domestic and sexual violence sectors just how overrun they are also to do good work. So I think this theme that kept popping up about how does this model really support collaboration is where there's such opportunity, because what might be liberated when you bring two relatively constrained sectors together to actually work together to sort of share the responsibility, share the way we're responding, and actually support each other in the work. And I think that's one of the real opportunities here, is the learning, but also the support, the camaraderie that comes around how do we work with this complexity. So yeah, just be interested to hear what folks are thinking about that, because I guess part of the opportunity here, appreciating the time constraints of general practice and the overrun realities of an under-resourced sector, we're trying to sort of spread this family, domestic and sexual violence informed response across the system more broadly. But yeah, that's going to come with its challenges, but it feels like the opportunity is within information sharing, collaboration, more of these sort of conversations that support people to share and to learn and to be doing this very much in real time together. I don't know what others sort of thought about that. Monique, what are your thoughts about that?
From the workshop that I attended, and it probably feeds into this whole theme of that collaboration, was this importance of the relationships, and, you know, that whole of practice approach, the reception staff knowing the community and maybe recognizing, you know, different signs, or, you know, living in those communities as well as knowing those victim survivors, or as well as, providing that safe place and how they do that in the practice. And I think often we have this focus on it's the GP's responsibility to provide that, recognize that. But I think some of, the interviews and all of that also refer to how do we branch this out more to allied health workers and nurses and social workers, the other health professionals, as well as community, because I think that was probably one of the biggest takeaways for me, was how much is happening in the community that we wouldn't have known of unless, we went out personally and did those visits. It's probably not something that people would necessarily share in a survey or questionnaire, but having those face-to-face conversations provided that opportunity. And, this also created that platform for people to come together and hear the other side, a GP side versus the specialized services, because we all work in this incredibly busy world, and we might not know what so-and-so is doing down the street, So having those incidental conversations, which has also been brought up, and learning, so I think not having that focus on that GP as being that sole person responsible for, recognizing and responding in that 15 minutes.
Yeah. I agree with that for sure. And I think it's mentioned within the report around, especially in our rural areas, a lot of the times the GPs can be locums, and so they don't have that relationship with the patient, but the relationship is built with the practice nurse or the receptionist or the practice manager, who does have that insight to be able to say, oh, I think something's going on. I think she's been a bit off, or this kid's been in multiple times in the last 6 months. I think we should look further into this. And they have that insight because they see that patient coming back over and over again. But I think there was also an amazing piece of empathy of when we brought both sides together and they realised that they both work in really difficult areas. GPs are generally paid per appointment, and they're only paid a percentage. So if they overrun their appointment, that's work that they're not getting paid for. And then on the other side, our specialist services are really underfunded and they're overworked, and they do have that burden of not being able to help everyone. And so I think there was this mutual empathy for both sides when we brought them all together.
Yeah, and I think just adding to that, the workshop that I went, just the recognition of the work that those specialized services are doing and them having an opportunity to share, which, as Martin also said, they shared really generously, and were happy, they felt safe in that space, to do that, I think was quite an accomplishment, in the way that the questions were framed and, the tools that they were given to answer the questions. And
and just extending on that sort of collective response in the practice, where you might not have just the sort of general practitioner or a specialist sort of responding or noticing on. I think given the prevalence of family, domestic and sexual violence, like, you have a lot of people with experience out in the community who see it actually, and who already are playing a role because they're already looking out for others. So this is where this sort of perception of specialization, professionalization of a response is not always the first way in. We see a lot in sort of peer-to-peer responses where people with lived experience can actually have a very, very different conversation with someone than even a GP, or when people have been through that experience and they know where people are at and they can see and they can actually say to them, like, I know actually how that feels, then that just opens up a very different pathway into support, and just even coming alongside them, they don't have to solve anything for them, they don't have to refer them to a service, but they can walk alongside them for a bit and just give them a bit of a platform to kind of move. So I think it was a real celebration of those informal supports that a community can offer, particularly if that's supported. Like you see sort of responses in the mental health space about about a whole of the community response to, like, okay, well, we all got sort of basic sort of mental health first aid training, so that there's just many places that would look out for you, and you can just say hello to and just check in and say you're having a tough time. So obviously there is a lot more complexities around, relationships and safety of people disclosing in community. But I think there's something in that anyway. And so just the number of informal services actually is probably a very safe place for disclosure for some. So just to think about that whole ecosystem of supports was something that we were quite interested in. That I think will be interesting to learn more about, and how the PHN could, support and nurture that sort of response.
I wonder what this sort of means when we are thinking about the priority population lens, appreciating all of the difference and beautiful diversity within that. I know that as a team, I think we've got some reflections of what might we have done differently within the process, and also just thinking about what might we do next in order to ensure that the implementation of the model is really meeting the needs of priority populations across beautiful Tasmania. I'm wondering what, as the priority populations team, Monique, I'm wondering, like, what just sort of comes up for you when you're thinking about this sort of collaboration and understanding the needs more broadly for priority populations?
Yes, I think this report gives us there's a lot of opportunity to explore those priority population groups, in a little bit more detail. And we've been given a lot of this information, reading through that. There's talk of, those from multicultural background and those specific cultural nuances that might not be addressed specifically in a rural and remote area, and how we support people from different backgrounds. So, as well as First Nations. And I suppose our learnings from this is, how do we have that focus of achieving that equity lens across all these priority population groups within family, domestic and sexual violence? And how do we do that when we are planning to go and do this engagement, from the start? With our First Nations, we what does that sort of consultation look like? Are we also going to meet them where they at in that sort of environment? And are there specific complexities, I suppose, to that group? So probably just more of being more knowledgeable around those specific priority population groups, and how we can then weave that into the program.
I'd agree with that, and I think it's definitely an area that we're getting better at as a primary health network, to make sure that we are meeting everyone where they are and doing it in a meaningful way. I think for us, definitely there's certain areas that this report has highlighted that will then need further work into the future, and I think more planning around that for us will be really important, but definitely voices that we need to hear more from.
Yeah, we were reflecting at Taxi about about what happened in this project. We certainly set out with the intent of engaging Aboriginal controlled organisations and working with them to understand better what those needs would be. I think that we were respectful of the feedback we heard, that it wasn't the right time to meet with some communities, but as always, the project timeline that we established. Nobody else established that. We established that. We have our own deadlines, and then so suddenly it's not possible to meet in that timeline, and so then this project-based approach, I guess, just immediately puts constraints around our ability to have a conversation and have a yarn about what actually might work and what is helpful help. I think that's the most plain language phrase that I always find so useful. It's just like, because like many, what we're referring to broadly as priority populations is this kind of people who are basically not being served by the current system. There's the fact that they are a priority population means that they are a priority for government and for PHN, because the environment which they're in is not conducive to their way of life, and or how they are in the world, or the situation that they're in. It's not so I think there's so much to be done about I guess the question I'm asking myself as a practitioner is, like, how do you step into that space and understand people's needs without that being a transactional or extractive sort of process? Like, why do I need to understand people's needs to then come back and say, okay, in that case, here's the funding arrangement? I'm holding a question around, how do we step into that space asking what is helpful help from the beginning without any constraints of, here's an EOI, here's the criteria for funding, here's the sorts of thing, here's the thing that we want to do, can you get something to fit in with that? It's like a bit of an existential question for the PHNs across Australia. Really, it's like, how do we do that? Like, it's and it's not easy. It's because of the role that as a commissioning body, as someone who manages funding, who how do you make sure that funding is going to places that is really effective? And sometimes that's leaning into those sort of community-based responses that we've seen are like so powerful, and you don't have to meet someone where they're at. They're already there. They're already doing stuff from a place-based point of view, and that all those trusted relationships are actually already there. So, I mean, one of the things that we heard was just like introducing somebody else into the conversation kind of sets everything back a bit. So how could we start a conversation that doesn't slow things down? How can we start a conversation that asks what helpful help is, and how that translates to the relationship between PHN and and priority population communities that are actually doing some really great work at a grassroots level. There's lots of questions. There's not so many answers there, but starting from a place of not knowing, I think, is okay sometimes. Respectful, curiosity, rather than give us all the knowledge and then we'll be able to tell you, sort of thing. So yeah, that's certainly from my practice point of view, that's something that I'm really working on and hoping to get better at. And when working with teams like yourself, it's how do we do that better? Yeah, that might not look like a project timeline approach. Yeah.
Yeah, I agree with you, Martin, and I think you summed that up really well. I think sometimes we do get stuck in that putting timelines on everything and making sure that we do it in certain stages, that we do sort of lose that lens. And I think for us, definitely looking more into our First Nations population and our core community is going to be a project that we need to do into the future, and make sure that we do it the way that it needs to be done for that community.
Along the timeline.
Yeah, not without timeline strengths on it probably, but I think you summed it up nicely before, that sometimes we do things a little backwards, and we do sort of try to make things fit into this funding guideline when we should be knowing what we need to action before.
true co-design process.
Yeah, exactly.
But I think, just having these conversations and bringing it to the forefront is already a big win. There could be some quick wins, like when you're looking at resources and all of that. How are we presenting resources to our First Nations community? What does that look like? Do we have translated resources? So having that, just being able to have that conversation at the start, I think is already a progression. And it came through in the report from a lot of the GPs and, from the sector about these priority population groups, which we may not have specifically targeted, but there are insights there that we can build on.
And it makes me think, as I've just been listening to you all, just thinking about the generosity of some of the folks with lived experience that offered up in this space, that have certainly backed up things that we've heard within this model in other places across Australia, is really thinking about, I've got a particular voice of somebody in my mind where they're saying, you can't underestimate that disclosure of violence could be the first time, the only time a person has ever said that. So there's such a important moment in time there where the response really matters. And again, from what we heard from incredible people with lived experience in Tasmania, which again was backed up by other folks, is then the power for general practice professionals to validate what they've heard. They have the power to validate, can make such immense difference to what the next conversation looks like, or the choices around support. So I think there's such a great opportunity now for Primary Health Tasmania to be thinking about, we know that the response matters. We know how integral the experience of validation is. So what does that mean? How might that need to look differently for different priority population groups across place? Because we've seen and we've heard that even within the time constraints of 15-minute appointments and other constraints, that those two things can be done and be done very, very well. So just thinking about that for next steps to how might we dig a bit deeper into the practice around that and the supports to deliver upon that.
Just touch on one other thing that was a sort of key, I guess, line of inquiry of the work was around what we're calling a service integrator role. Not only shifting specialization and the knowledge that comes from a specialist through training into GPs and medical practices, but actually having somebody turning up and being part of your practice, and the opportunities for delivering training not as a series of modules online, but actually an in practice, in situ experience that that might look like a discussion with a local medical center about where are we at, what are we doing, what are our practices around this, what are our so that we can sort of start shifting through some of that unknown, or oh gosh, am I allowed to do that, is that part of my role, is that sort of thing. So having a discussion at a practice level and then building people's capability to be able to do that, not only to recognize, but that first response, Carla, to your point, that disclosure might happen to anyone. We've certainly heard, someone that's doing the appointment before the GP actually sees, I'm just going to take your temperature, I'm just going to take your blood pressure, that sort of thing. Maybe it happens then, so then is that person ready to make that first response, and just, so often just to believe what we're like, to acknowledge and validate what they're hearing, being an extraordinary moment for that person, and just to know what that next step might be, and just to know what the right response might be at that time, and that there are many different ways of responding at that time. There's some really amazing opportunities to transfer knowledge through that service integrator role, but also to add capability to that practice model. So even if it's an occasional kind of visit, that also allows that specialism to not just be located in the big centres in Hobart and Launceston, but also in more rural areas, and to travel around. And though of course that builds up the opportunity for the program or whatever that program is to learn from lots of different places, and then to what does that look like as it scales. And so there's lots of learning built into the recommendations here as well. So I think it's not a report that says, okay, great, we've found all this out and this is the exact next thing you should do. It's this is what you need to learn, and perhaps some of the ways that you could learn doing that, which, as we all know, starts with relationships. And I think that's what we were trying to do today, with a bit of a discussion about how we might go forward and work with the different communities and the different people around Tasmania that are already doing such great work. The huge amount of energy and passion that is in this sector that we saw every day when we went to speak to people. It was such a privilege. It's just an extraordinary part of human nature to kind of step into what is a pretty confronting space, and just to show up and just be another extraordinary human being, of which there are many that we met. So I think how do you build those relationships, and how do you celebrate people's good work, and then join some of it up so that it makes a really big difference and creates different pathways for people in Tasmania.
And I think to build on us discussing priority populations within Tasmania, it's not only our obviously our call that our First Nations communities are one that we steer to when we say priority populations, but for family domestic violence, that's generally women and children as well. But within Tasmania, I know we have, for Australia, one of the highest percentage of young people getting, I think we've got 17% of our women experience abuse before the age of 15, which is a huge percentage. And then we had sexual assaults were 60% of the victims were under 18. So I think that's a really important age bracket that we'd have to look into as a priority population, because the way that family domestic and sexual violence is responded to within that younger population really steers what the rest of their life looks like for them. So really important to name them up as well.
That's such an important point, Holly. So important. I wonder what, having had today's yarn and thinking about the report, I'm just interested, maybe it's just a bit more of another reflection, but just wondering what your hopes are or your thoughts are for next steps for the Primary Health Tasmania team. What's front of mind for you as you go into 2025 with this work?
I was just going to say, for me, I think the most important thing that I think moving forward is making sure that we do educate our primary care providers on the best way to recognise, respond and refer, and that's really making sure that the education piece that we roll out as a PHN is really tailored to meet them where they are. We have a vast variety of practices across Tasmania, and their level of knowledge around family domestic violence is very different in each space. So making sure that we do have different levels of education and how to support them in that recognising and responding and referring is a big area for us to make sure that we get right moving forward.
I'd add to that the embedding of the service integrator role and the learnings that will hopefully gain from that, which we can then build on.
And I was going to say, we are fortunate, maybe, that we are a single PHN in the States, whereas the other states have multiple PHNs. So I think there's a real opportunity as well to acknowledge us, those that we have consulted with and engaged with and build on. I think for me that state engagement, really building on those relationships that we fostered, and giving back as well. People have invested a lot of time and have been so generous in what they've shared with us. And we are in that unique position that we are across the whole of Tasmania, and we can build on those relationships without so build on this work. So I think that's a really important part going into the new year for me.
And I think a lucky thing for us in Tasmania is everyone that you speak to is really positive around what we're doing and what everyone else within Tasmania are doing, and they really want to be involved and help you move this sort of thing forward. And so it just gives us a little bit of leverage when we're going out to make some sort of change, that we already have that sort of buy-in with the community, the specialised services, our general practices. We're just super lucky in that space.
Yeah, I think, people, from the website, it got quite emotional. People just want to be heard, and they just wanted, someone to listen, and we provided that. But now we also, we have to take this information and we have to, move forward with this and build on what we've learned. And like we said, with some of the priority population groups, really invest some time in trying to understand those communities and a bit better than what we've done in here. And granted, we came into this process knowing that we didn't have a lot of data, so we were sort of trying to capture everything. And now, we can sort of drill down a bit, from the information that we have all been able to get with this report. It would be interesting to hear what Tim has to say. So Tim sort of came in after all of this has been done, but has been doing a lot of summarizing of the report, and I wouldn't say an outsider, but an outsider to the process, and wasn't at any of the workshops. What?
Thanks, Marique. I'd agree with yourself, Andrew and Holly. I think it's so important to continue these conversations because so much good work has been done with the community. So I think it's really important to keep those conversations going, and particularly moving into 2025, provide support for the service integrator position, and also developing, for example, community of practice to provide support in that way. So hopefully bringing the people in the community together to work with those with lived experience with this very important issue.
I feel like we could talk all day about this, but it's a real privilege to be part of a piece of work that actually allows a lot of people to talk into a process in a very varied way, but also to have some really concrete kind of actions kind of coming out of it. And it's really, I think we've identified so many quick wins for that education piece that you're talking about, Holly, and but also the sort of, just the practical support of that service integrator role, and a real intent to kind of work with everybody that we've started building relationships with, and just to continue those relationships and working together into 2025. But thanks everyone for a really amazing chat today. It's really a super project and super to be able to work with people in Tasmania. Certainly from my point of view, I'm very grateful for the opportunity and everyone we've met along the way. But any final words to close this out?
I'd just like to thank you guys at Taxi as well. I don't think that we would have got the richness of information without you guys being on board. And I think we're just really privileged as a PHT to have this funding and to be able to be a small drop in the ocean in it moving forward to, end family and domestic violence is the main goal for everyone. So I think we're really privileged to be a part of that sort of movement going forward.
That's all from us today. Thanks for joining us.